Welcome to my YouTube channel. Today we are going to talk about preeclampsia. Kindly make sure you subscribe. It will cost you absolutely nothing.
Preeclampsia is a multi-system disorder of unknown etiology characterized by development of hypertension. And this hypertension is to the extent of 140 to 160 millimeters of mercury or more, with proteinuria and after 20 weeks of gestation in a previous normotensive and non-proteinuric patient. Or you can have this increased blood pressure, and with patient who comes in with severe features of preeclampsia. You also categorize that as preeclampsia. Risk factors: premigravity, Pre-paternity, mother who is greater than 35 years old, history of pregnancy-induced hypertension, pre-existing maternal conditions such as renal disease, chronic hypertension, diabetes, obesity, autoimmune, multiple gestation, molar pregnancy, smoking is known to be a protective factor against preeclampsia. As we stated before, preeclampsia is a multisystem disorder of unknown etiology. However, disease theories have been proposed, and we have multiple proposed etiologies, which could be genetic, immunologic, hormonal, environmental, among others. And preeclampsia usually complicate 5 to 7% of all pregnancies. Pathophysiology behind preeclampsia. In preeclampsia, we normally have inadequate trophoblastic invasion. So the sincere trophoblasts normally invade the spiral artery. These are the spiral artery as mentioned. So you can see spiral artery. So they normally invade spiral artery, creating a low resistance. So if you know our normal physics, if we have a large lumen, then we are going to have low resistance. However, in preeclampsia, we have inadequate invasion of this trophoblastic invasion, as you can see here. So therefore, we will resort to high resistance uteroplacental circulation, therefore causing preeclampsia. So we continue. So this is just a repetition. Pathophysiology, it's a multifactorial initial etiology, as we mentioned before, which usually result in inadequate trophoblastic invasion. And the sincere trophoblastic, which normally invades the uterine spiral artery to establish a low resistance uteroplacental circulation, don't do so. So failure to do so then results to subsequent impairment of uteroplacental perfusion. So now, because you have inadequate uteroplacental perfusion, therefore you'll have placental ischemia, which then will result to oxidative stress and production of toxin, which now enter circulation. When this toxin enter circulation, you'll now have widespread inflammation, endothelial injury, and dysfunction leading to arterial permeability, and then you can have inappropriate activation of the coagulation. So the net effect of the processes that you have talked about will result to widespread vasoconstriction resulting to systemic hypertension and ischemic in various vascular beds. In addition to that, you're going to have extravasation of fluid from the intracellular space. This is because already the vascular membrane, or you have increased the membrane permeability. Also, you'll have intravascular coagulation with progressive consumption of coagulopathy. So just as a repetition, so we say the pathophysiology is caused by inadequate invasion of the cystotrophoblastic cells in the spiral artery, resulting to high resistance uteroplacental circulation. When you have reduced uteroplacental circulation, then you're going to have ischemia, and that ischemia is going to produce toxins. And now when you have these toxins are going to enter into the bloodstream, causing inflammation, increasing permeability, and also coagulopathy. So this is a summary of the pathophysiology, where you have weak or inadequate trophoblastic differentiation during the process of endothelial invasion. This now will result to abnormal development and remodeling of the spiral artery in the deep myometrial tissue. So later you'll have a high uteroplacental circulation and later have placental hypoperfusion and ischemia. So this now will result to toxins that will be producing that will now enter the bloodstream and now cause cascade of inflammation with placental release of cytokines, as I said before, disrupting the balance of angiogenic factors and inducing platelet aggregation. So in result, you are going to have systemic endothelial dysfunction and later have systemic hypertension. So the pathology will concern the placenta, which we said is lack of decidualization of the myometrial segment of the spiral artery. So normally, the invasion of the spiral artery by the trophoblastic tissue results in the replacement of muscular and elastic layers of the spiral artery by fibrinoid and fibrous tissue, therefore resulting to large, tortuous, low resistance channel that extend through the myometrium, as previously mentioned. So when you don't have this, you're going to have narrow and high resistance channel. In preeclampsia, such changes are mostly limited to the decidual segment of the vessel. As such, the myometrial segments of the vessel have reduction in diameter, I said before, compared to that of a normal placenta. Glomerular capillary endotheliosis, as it said before, that you're going to have inflammation and production of cytokines because of the toxins that are released due to the placental ischemia. So this will result to glomerular capillary endotheliosis, which will have marked swelling of the glomerular capillary endothelium with marked deposits of fibroid material in and beneath the cells. In addition to that, we said that you're also going to be having ischemia in vascular beds. So you're going to have ischemia, hemorrhage, necrosis in multiple organs. Preeclampsia clinical features. We are going to divide this in a very systematic manner. We are going to deal first of all with the maternal features, and then now we are going to deal with fetal features later. So the first one is weight gain or edema. And just to elaborate this, we say that you are going to have extravasation of the fluid from the intracellular to the extracellular. So this is one of the great contributing factors that you are going to have, weight gain and edema. So this is one of the earliest signs of preeclampsia. And as I said before, this is due to extravasation of fluid secondary to increased capillary permeability, and it may also manifest as an increased hematocrit due to hemoconcentration. So while preeclamptic patient may have an increased total body fluid volume, they are relatively intravascular volume depleted due to the extravasation of fluid. So we have two spaces, the intravascular and the extravascular. So what happens in preeclampsia, because of increased permeability caused by inflammation and cytokines, then we are going to have fluid moving from the intracellular space to the extracellular space. Kindly note that if you meet up this patient, then the first thing that you're going to have to do is resuscitate in terms of fluid, because already we have intravascular volume depleted. So we continue the clinical features, that's the maternal clinical features, where you're going to have systemic hypertension. And this is because in the pathophysiology behind preeclampsia, you're going to have ischemic, placenta ischemic, and that is going to produce toxin into the bloodstream, causing vasoconstriction, causing increased permeability, among other factors. So you're going to have widespread vasoconstriction, and in addition to that, that vasoconstriction is going to increase the peripheral pressure, vascular resistance, meaning the diastolic pressure particularly will be affected because of that. So diastolic pressure is particularly affected as it is more closely reflects the arise of peripheral vascular resistance. So that one is renal impairment. Also note that we are going to have widespread vasoconstriction, so it is occurring even in major organs. So vascular arterial vasoconstriction, glomerular arterial vasoconstriction results in decreased glomerular filtration rate. So if you have decreased glomerular filtration rate, then you're going to have an oligouric, that is small urine, or even anuria, that is no urine at all. So altered glomerular capillary permeability also results in proteinuria, and that's why we said one of the definition of preeclampsia is when you have elevated BP of 114, 190, or when in addition to that you have proteinuria or severe features of preeclampsia. So the other one is coagulopathy, and as we noted in the pathophysiology behind preeclampsia, you're going to have increased platelet aggregation among those factors, and this is due to thrombocytopenia most commonly, and you can also have disseminated intravascular coagulation may occur as well, especially in the context of placenta ablation, complicating preeclampsia. So the third one is liver impairment. We say that you're going to have widespread vasoconstriction. So systemic constriction result in ischemic damage to the liver, resulting to focal hemorrhages and infarction. And these usually present as right upper quadrant pain or epigastric pain, and rarely you can have an hepatic rupture. So in terms of neurological impairment, this vasoconstriction is going to go to most organs. You're going to have visual field disturbances, new onset headache, hyperreflexia or clonus, seizures, which we said, seizures when you have preeclampsia and now accompanied by tonic-clonic seizures, not attributable to any other causes of seizures, then that is eclampsia. In addition to that, you're also going to have cardiopulmonary impairment, where you're going to have pulmonary edema. So in terms of symptoms, it's just a kind of repetitions of what you have talked about in clinical in clinical features, or just simplifying the visions without the pathophysiology. So the mild symptoms, as we talked before, we are going to have slightly swelling over the ankles, that is the edema, and gradual swelling extending to the face, abdominal, vulva, or even the whole body. And alarming symptoms, these alarming symptoms are mostly neurological, liver, and kidney, where you're going to have headache, which could be frontal or occipital, disturbed sleep, diminished urine output, which is it could be anuria or oliguria, and less than 400 ml per 24 hours. Eye symptoms, which you could have blurry or dimness of vision, and epigastric pain, which you've really explained the pathophysiology behind it. So in terms of signs is what you see. You as a clinician, you're going to note abnormal weight gain that is greater than 2.2 kgs in 1 month, or 450 grams in 1 week. In addition to that, persistent rise in BP, that is more than 140 to 190 millimeters of mercury. Visible edema, as I've talked about, over the ankles, hand, face, from the rise of the bed at the morning. Also, signs of pulmonary edema, abdominal examination will reveal epigastric pain because we said we have liver involvement. In addition to that, you're also going to note when you're doing an obstetric examination, you're going to note scaty or intrauterine growth restriction. This is because of chronic placenta insufficiency. So in terms of systems, we have a very good summary that's in this table. So CNS, you're going to have eclampsia. As you see, this is when you have generatonic seizures that are not attributable to any other causes. You can also have hypertensive encephalopathy, intracranial hemorrhage, cerebral edema, cortical blindness, and cranial nerve palsies. In terms of renal, you're going to have reduced GFR, as we talked before, proteinuria, increased serum uric acid, creatinine. So if you're going to have this, then you're also going to have if you're going to have reduced glomerular filtration rate, meaning that you cannot filter things, then you're going to have increased serum uric acid, in addition to increased creatinine, increased urea. And you're so because you have reduced glomerular filtration rate, you're also going to have oligo and anuria, and that will predispose the patient to have AKI, so acute kidney injury. So in terms of liver, epigastric or right upper quadrant pain, as we talked about, you're going to have abnormal liver enzyme, where you have the capsule or hematomas, and it ruptures, then you're going to have hepatic capsule rupture or HELP syndrome. So in terms of hematology, we have discussed this just as a summary: decreased plasma volume, hemoconcentration, thrombocytopenia, hemolysis, and DIC. CVS, we said pulmonary edema, pulmonary embolism, future hypertension. In terms of placenta, we are going to say intrauterine growth restriction, placenta abruption, and intrauterine demise of death. So in terms of placental fetal manifestation, it's just a repetition of what we have talked about. And just to repeat what you have talked about in the previous layer, because we said we are going to have chronic placental insufficiency, then we will have intrauterine growth restriction, intrauterine growth demise, and fulica, that is oligohydramnios. So intrauterine growth restriction, which is usually asymmetry, intrauterine fetal demise, that is demise, oligohydramnios, and then you can have placenta abruption. So grades of preeclampsia. Grades of preeclampsia are defined according to severity, and we have two grades of preeclampsia: preeclampsia with severe features and preeclampsia without severe features. So the severity of preeclampsia can be graded by diastolic and or systolic blood pressure, the amount of proteinuria, signs and symptoms of severe features, lab results indicating liver, renal disease or clotting deficiency, and presence of a convulsion. And the presence of a convulsion, that we will get that to be a eclampsia. So mild preeclampsia or preeclampsia without severe features is when you have a diastolic pressure of 90 to 109 millimeters of mercury, or a systolic blood pressure of 140 to 159 millimeters of mercury with proteinuria. So I hope you have gotten that. The ranges, that is 90 to 109, 140 to 159. So if it goes beyond that, then that is called severe preeclampsia with severe features.
So preeclampsia with severe features or severe preeclampsia can be defined by any of the following, where you have a diastolic blood pressure of 110 millimeters of mercury or more, and or a systolic blood pressure of 160 millimeters of mercury or more on two occasions 4 hours apart. So, or when you have a diastolic blood pressure of 140 millimeters of mercury or more, and or a systolic blood pressure of 170 millimeters of mercury or more on one occasion. So the difference between these is you have 110, 160, but on two occasions, 4 hours apart. And the second one is when you have 170, 120 on one occasion. So, and the severe features which we're going to see in the next slide, abnormal laboratory results indicating severe disease. And these abnormal laboratory results are usually involving the platelets, the liver, and the renal. So a serum creatinine of 90 millimoles per liter or more indicating abnormal renal function. So in preeclampsia, we are going to have reduced GFR, and if you're going to have reduced GFR, then you are not able then to excrete creatinine or urea. So increase of creatinine greater than 90 millimeters of millimoles per liter or more, then it's an indication of abnormal renal function. Or an alanine aminotransferase or aspartate aminotransferase of 40 international units indicating liver disease, or platelets less than 100,000 microliters. So the severe features or the severe features that we're talking about, we have signs and we have symptoms. So you can categorize them from head to toe, where in the head you're going to have headache, you're also going to have blurry vision, you're also going to have visual or flashes of light in front of the eyes, blindness, among other factors such as altered mental status. So when you go downwards, you're going to have pulmonary edema, and that may be seen as dyspnea. When you go downwards, you're going to have epigastric pain, that is in the liver. You're going to have epigastric pain, and then when you go downwards into the kidney, in the kidney we said you're going to have reduced GFR. So that will present as oliguria or anuria. So this suggests some of the severe clinical features, and they include severe headache, visual or flash of light seen in front of the eyes, blindness, dyspnea, altered mental status, upper abdominal pain in the epigastric or over the liver. And then signs include tenderness over the liver, increased tendon reflexes. These are knee reflexes and clonus. Then you can have pulmonary edema and ascites. So the severe features of the CNS include blurry vision, scotomata, altered mental status, severe headache, and revealed by acetaminophen. And then we have symptoms of the liver capsule distension, which include epigastric pain or right upper quadrant pain, nausea and vomiting, and elevation of the liver enzymes, that is AST and ALT, greater than 2 times the normal. So systolic blood pressure, which you have seen, which will define it as greater than 160 or 160 to 110, sorry, on two occasions, 4 hours apart, or 170, 120 on one of the occasion. Platelets you can have less than 1,000 count. Urine output, we said you're going to have oliguria or anuria, that is less than 500. Then pulmonary edema, which can present as cyanosis, stroke, and progressive renal insufficiency, which we said you are going to have reduced GFR, therefore presenting as such. So urinary creatinine to be greater than 1.1 milligrams per dl, or doubling of the serum creatinine in women without renal disease. So complication of preeclampsia, we have maternal and we have fetal. So in terms of maternal, preeclampsia means pre and then eclampsia. So kinda before eclampsia. Meaning if preeclampsia occurs, we have a higher chance of having eclampsia. So one of the complications is eclampsia, and this is presence of general clonic seizures not attributable to any other cause occurring during or after 48 hours after pregnancy. And then you can have HELP syndrome, which can progress to DIC, placenta abruption, stroke, liver damage, kidney injury, as we talked before. And then complication, as you have divided them, you can have maternal complications, and this is during pregnancy, where you can have eclampsia, antepartum hemorrhage such as a placental abruption, acute renal failure because you said you have reduced GFR and accumulation of those creatinine and electrolytes into the blood, cardiac failure, HELP syndrome, vision problem, premature labor. And then during labor, you can have eclampsia, postpartum hemorrhage, shock, and then puerperium, that is post-delivery, you can have eclampsia, puerperal sepsis, and shock. So in terms of a complication, fetal complication, you may have intrauterine death, intrauterine growth restriction, birth asphyxia, and prematurity. While remote complication, you can have residual hypertension and recurrent preeclampsia. So remote complication, this residual hypertension is where you had preeclampsia, but now after pregnancy you have a higher chance of having hypertension, and then the next pregnancy you are going to have an increased risk of having preeclampsia. Complications, again, fetal. So preterm delivery is often necessary because obviously deterioration of maternal condition and development of fetal distress. And then, as you said before, placenta abruption is common in patients with preeclampsia and often results to intrauterine death. Preeclampsia is also often associated with decreased placental blood flow. So if when you have decreased placental blood flow, then you are going to have intrauterine growth restriction and intrauterine growth death. As a result of, so what I was to say, as a result of decreased placental blood flow to the fetus, then you're going to have intrauterine growth restriction and fetal distress. So investigation, preeclampsia is diagnosed by the presence of hypertension, as we said, greater than 140 and greater than 90. And proteinuria, presence of proteinuria. So protein in urine can be detected by urine dipstick and then quantified through 24-hour urine collection. So these are other investigations that can be done to monitor signs of organ dysfunction or signs of severity of preeclampsia. So the first one is full blood count, where you HB will be decreased and platelet will be also decreased. Urea and electrolytes, where you have increased urea, increased creatinine, increased urate. And the reason behind this is because you already have a decreased glomerular filtration rate, meaning you are able to filter less blood to go through into remove such kind of things. And this is in the serum, and you're going to have decreased urine output because also of reduced glomerular filtration rate. Liver function tests, as you said before, they're going to be increased, that is increased ALT and increased LST. And fetal well-being, where you do an ST or an obstetric ultrasound. So this is just a repetition, and where we said blood test, you're going to do full blood count, and you're going to see a decrease in HB and also a decrease in platelet. So anemia secondary to hemolysis, thrombocytopenia, and decreased coagulation factors. Urine analysis, you're going to see anuria or decreased urine output. You're also going to see increased creatinine, urate, and urea in the blood. So in addition to proteinuria, so proteinuria, high iron chi, specific gravity is also increased. So liver function test, you're going to see elevated in LT and ST increase. Also alkaline and lactate dehydrogenase also increase in serum albumin. So renal, as you said, uric acid is also going to increase and serum creatinine will be elevated. Other tests that you can do an ECG, placenta function, fetal maturity, and cerebral angiography. Management of preeclampsia, we're going to begin with prevention. And in terms of prevention, the first thing that you can administer is calcium supplementation. However, it is noted to be effective only in high-risk women, but not effective in low-risk women. The next thing you can administer is aspirin, which is antithrombolytic. And this is baby aspirin, that is low-dose aspirin, that is 81 mg per day. Prophylaxis is recommended in women who are at a higher risk of preeclampsia and should be initiated between 12 and 28 weeks of gestation, and optimally before 16 weeks of gestation. And this baby aspirin is to be given daily and to be discontinued until delivery. So you also ensure good prenatal care and regular visit, and through this you are able to identify early diagnosis of patients who do not have such conditions. Kindly note, eclampsia, which is when you have preeclampsia in addition to conversion, cannot always be prevented. It may occur sudden without any warning. So in terms of management, we have the principles of management, where the first one is to prevent conversion. So already I have preeclampsia. The first thing I have to note is to prevent convulsion, because preeclampsia is just before eclampsia. So prevent eclampsia and then regulate the blood pressure, and delivery is the definitive management of preeclampsia, because in preeclampsia, who is the problem? Placenta is the problem. So when you deliver, meaning you have delivered the placenta, you have cured the problem. So management of mild preeclampsia or preeclampsia without severe features. I think the key word to get here is to give the patient bed rest. Number 2, to ensure that we don't progress to severe preeclampsia. Number 3 is to deliver. So that's just what we're going to talk about here. So bed rest and daily weighing. Daily weighing is helpful in terms of, if you know this patient will be predisposed in extravasation of fluid from intravascular to extravascular, mean this patient will have increased weight gain due to edema. So you daily monitor that weight to see, are we progressing to the severe end or are we really improving? Next is hospitalization, and if you cannot, home regimen antihypertensives, and then daily urine dipstick measurement of proteinuria. So this proteinuria that you already have, is it worsening or is it improving? And then blood pressure monitoring, and then fetal heart rate testing, and then periodic 24-hour urine collection. You do an ultrasound for the baby, liver function test, renal function test, coagulation profile, and then later you deliver. So just to note is you ensure the patient has gone for bed rest, and ensure that you give hypertensives, and we don't progress to severe preeclampsia, meaning that we monitor liver function test, renal function test, coagulation. We also monitor the blood pressure and even dipstick, among other factors. So definitive treatment obvious for preeclampsia, as I said before, is delivery. However, the risk of early delivery is balanced against the gestational age and the severity of preeclampsia and response to other treatment. So for example, if the baby is less than 34 weeks, then you are ish on when to deliver or not. If the severity of preeclampsia then is more of severe, then you are prone to deliver earlier compared to preeclampsia without severe features. And then respond to treatment. So if the treatment that you're given is not responsive, then meaning that we will continue having an elevated blood pressure, which will predispose to increased mortality of the mother, then we will lean on the side of going to deliver. So usually immediate delivery after maternal stabilization, e.g. when you have controlled your seizures or when you're beginning to control blood pressure, is indicated in pregnancies that are greater than 37 weeks, when you have eclampsia. When you have eclampsia, kindly note, when you have eclampsia, make sure you can deliver this mother within at least 18 hours. And then preeclampsia with severe features. If you have eclampsia with severe features, then you go to delivery. If the pregnancy is greater than 34 weeks, or when you have deteriorating renal, pulmonary, cardiac, hepatic function, or when you have non-reassuring fetal status. Kindly make sure that you are in a battle between two things, the mother and the fetus, and you have to be given a decision to choose between the mothers and the fetus. Who you choose? Obviously the mother. So you put the mother's health first, then the fetal's health second. So if then you have something that is interfering or that is deteriorating the mother's health condition, then you have to go and deliver, at least to rescue the life of the mother. Management of severe preeclampsia. So the first thing we're going to do is to prevent convulsion, and with that you're going to give magnesium sulfate. The next thing you're going to do is control maternal BP, and through that you're going to use antihypertensives, and the hypertensives that you're going to use is labetalol, nifedipine, medeldopa, and hydralazine. And then the third thing is delivery. So when do you deliver? You can deliver if the fetus is greater than 34 weeks. So this is the definitive mode of delivery if severe preeclampsia develops, or if there's evidence of fetal lung maturity, that is when the fetus has reached around 34 to 36 weeks, or when there's fetal and especially maternal jeopardy. And then you also observe the signs and dangers of uh, preeclampsia, that is severe headaches, epigastric pain, visual disturbance, among others. So if there's any doubt about the grade of preeclampsia, then the patient should always be placed in a more severe grade. So patients who improve on bed rest should be kept. So if a patient came in with severe preeclampsia and they have improved dramatically, then you don't take that patient from severe preeclampsia to mild. You keep the patient in that grade that they came initially. So patients who improved on bed rest should be kept in the grade of preeclampsia, which they were given at the initial evaluation on admission. And then the diagnosis of preeclampsia with severe features is made only one of the symptoms or signs is present, irrespective of the blood pressure or the amount of proteinuria. This statement means that severe preeclampsia can be made if there is a severe signs or symptoms, irrespective of the blood pressure or proteinuria. So when preeclampsia arises in early second trimester, that is 14 to 20 weeks, then you'll be like suspecting, what did we define preeclampsia is? Preeclampsia is when you have elevated blood pressure with proteinuria or severe features of preeclampsia when the patient is greater than 20 weeks of gestation. So now it has developed 14 to 20 weeks. Then you suspect that may not be preeclampsia. So what that may be, it may be an hydatidiform mole or choriocarcinoma, which should be considered, which can present as preeclampsia. Delivery, which is our definitive therapy or a definitive treatment. When can you deliver? Let's just recap from what you have said. You said we can deliver, number one, if it's eclampsia, that is number one. Number two, if there are severe features of preeclampsia, which I've talked in detail about. Number three, if this fetus or maternal, the mother or the fetus is being compromised in terms of end organ failure, and there's increased mortality of the mother or the fetus, or when the pregnancy is near term, that is greater than 34 weeks. So preeclampsia close at term or close to term, that is greater than 34 weeks, where the fetus has achieved lung maturity. Then impaired maternal end organ, as we have mentioned before, compromised fetal growth or impaired placental function or non-assuring fetal status, and eclampsia, as we mentioned before. So it is the mode of delivery. Vaginal is preferred unless it's an obstetric indication. Then cesarean can be preferred. And then before, if you deliver a pregnancy that is before 34 weeks, then you have to give corticosteroids for what? For lung maturation. In addition to lung maturation, what does corticosteroid help about? So you can comment in the comment section. Apart from corticosteroids helping the child to achieve lung maturity, what else does it prevent? And there are three key of them. So if you need to get to know those key three of them, I have a video on anticorticosteroids. You can go and visit them. Thank you.